The topic for discussion today is stomatitis. As the name itself indicates, stoma is mouth and itis is inflammation. Stomatitis is actually a condition which can directly manifest itself as one of an entity, or it can be a condition which is because of any underlying or any other systemic conditions that are present in the body. As stomatitis is also called as gingival stomatitis because most of the times gingiva is also involved along with other oral mucosal tissues such as buccal mucosa, palate, tongue, etc. Stomatitis usually manifests as it has all those inflammatory characters like inflammatory characters of rubor, calor and duber, which means pain, burning sensation, erythema, and patient will also have some difficulty in swallowing, eating, etc. Usually these lesions or the ulcers, vesicles or just the erythema within the oral mucosa can have manifestations which will include pain and erosions, ulcerations. Sometimes they may also lead to hemorrhagic conditions. Usually this can be either acute or a chronic type of conditions. Coming to the etiology, there are various etiological agents for stomatitis which will include infections, infectious agents such as viruses, bacteria, fungal, other protozoal infections can also be seen, but most commonly bacterial, viral and fungal infections cause stomatitis. Various bacterial infections which actually cause this stomatitis include Campylobacter, spirochetes, which include treponema, and other streptococcus infections, which will actually be a super infection there. And then fungal infections, the most common cause of stomatitis in fungal agents are Candida. Candida albicans is one of the most common causative organism for stomatitis in the oral cavity. Other fungal infections which will be actually causing deep fungal infections mostly manifest as single ulcers, also present, which include histoplasmosis, cryptococcosis, coccidiomycosis, etc. Various other viral etiological agents are also present which will cause stomatitis. They include herpes simplex virus, which is most commonly common virus that will cause this stomatitis, especially HSV1, that is herpes simplex virus 1 is the most common causative organism of stomatitis in head and neck region. Next, other viruses which include cytomegalovirus, and then we also have herpangina conditions which are caused herpangina like conditions also are present, and then trauma is one other etiological agent for stomatitis. Usually this trauma is localized, most commonly caused because of any tooth bite or cheek biting, which will cause morsicacia vocarum, and other traumatic agents include poking with needles or any toothpick. Sometimes chemical or physical agents can also lead to these traumatic ulcers, which include aspirin or local burn and hot pizza burns, etc. Other conditions which are responsible for this stomatitis include inflammatory conditions and autoimmune conditions. Inflammatory conditions include T lymphocytic infiltration, which will most commonly cause lichen planus like conditions and lichen planus or lichenoid reactions, and other autoimmune conditions are also present, which most commonly is pemphigoid like lesions. Here what happens is body itself produce autoantibodies. These autoantibodies will attack the desmoglein proteins, either desmoglein 1 or 3, and because we are talking about stomatitis, desmoglein 3 is most commonly involved for mucosal lesions in autoimmune disorders. Other autoimmune conditions can also are present, which include erythema multiforme, Stevens-Johnson's, Lyell's disease, etc., which all contribute to stomatitis. And other important etiological factor is nutritional deficiency. Various nutritional factors like iron deficiency, zinc deficiency, vitamin B deficiency, C vitamin deficiency, all these also contribute for various stomatitis. For example, iron deficiency most commonly seen in females, or in case of severe iron deficiency conditions, oral mucosa appears paler. Along with this condition, there will also be burning sensation within the oral cavity, which will lead to glossodynia, glossoptosis like condition, glossopyrosis. Glossopyrosis is a condition which will, glosso is tongue, pyrosis is burning sensation. It is nothing but burning sensation of tongue. Glossodynia, as the name itself indicates, glosso is tongue and dynia is pain, which is nothing but pain of the tongue. So iron deficiency, especially in iron deficiency anemia or sideropenic anemia, in this it is also called as hysterical anemia. In this condition, there will be difficulty in swallowing also. Other zinc deficiencies and vitamin B deficiency and vitamin C. It is most commonly called as scorbutic gingivitis, where there will be inflammation of gingiva, where gingiva is easily bruisable, resulting in ulcers and hemorrhagic lesions, where it will also have pain and inflammatory conditions around the gingiva. So these are various etiological conditions that will cause stomatitis. And other variants that are most commonly present are allergic contact stomatitis, denture related stomatitis, nutrition related stomatitis. It is nothing but based on the etiological agent, these different variants of stomatitis can be seen. For example, the first one, where it is allergic stomatitis. Some people are allergic to certain food or any material. For example, latex allergy. Usually when patient comes to us, the primary thing what a dentist does is he wears a glove, he or she wears a gloves and check the patient. In case of this latex allergy, when we touch the patient's mucosa, because of this allergic reaction where lymphocytic production will be happening at the local region, there will be erythema and patient will land up into pain and burning sensation. Usually this will last for about a few days, in like about 3 to 4 days in time, and it heals spontaneously unless it is very severe allergic form it takes place. Other thing, in this allergic contact stomatitis itself, we have various variants like allergic stomatitis veninata, stomatitis medicamentosa, etc. Stomatitis medicamentosa is a condition where a medicine which is probably allergic to the patient is placed within the oral cavity, then they will have a localized allergic reaction. Stomatitis veninata is when patient he takes it orally, and that manifestation can be seen in the oral cavity. So these are various types of allergic stomatitis and allergic contact stomatitis. Then coming to denture related stomatitis. This is one of the common type of stomatitis that is actually seen in elderly patients or patients who are using dentures, especially the removable partial dentures or complete dentures. In this case, what happens is, if the patient does not maintain his or her dentures properly, if the denture is not washed properly, or if the denture is being used for a long term, in those cases what happens is, beneath the denture there will be candidal growth or other microbial organisms growth will be seen, which in turn will cause inflammation of the palate or the areas wherever the denture base is touching the mucosa. In these conditions also it will lead to stomatitis. And other conditions are nutritional deficiency, which I have already discussed. And this is a picture of allergic contact stomatitis, where patient was allergic to latex and hence there was erythema on the buccal mucosa. And other infections that causes this stomatitis are herpetic gingival stomatitis, where I already explained where HSV1 is the most common causative organism. Here what happens is, when the patient was inoculated with HSV virus, HSV1, then there will be a local eruption of vesicles, which in turn will break and lead to ulcers. These ulcers are usually very pinpoint and they coalesce to form one big large ulcer. The most common site of this herpetic gingival stomatitis, as the name itself indicates, is keratinized mucosa. So most commonly it manifests on the palate, on the gingiva and on the tongue. But recently there is evidence that is HSV1 induced ulcers can also occur on various parts of the oral mucosa. Then next is candidiasis. In this candidiasis also we have various types like acute erythematous candidiasis, we have chronic erythematous candidiasis, denture induced candidiasis, etc. where the primary causative organism still remains the same, which is nothing but Candida albicans. And next we have bacterial conditions, which are NEET and NEET. It was initially called as acute necrotizing ulcerative periodontitis, but it was recently renamed as NEET, which is necrotizing ulcerative periodontitis, which includes the stomatitis condition where ulcerations are seen on the gingiva, which further on progression will leads into necrotizing periodontitis also. And other viruses which we discussed were cytomegalovirus. Herpes zoster virus is also one of the common cause, where dermatomal distribution of herpes zoster or zostriform distribution is seen. Most commonly involved in the head and neck region is trigeminal nerve, trigeminal ganglion, and along all these three branches, that is ophthalmic, maxillary and mandibular branches, there will be ulceration seen. Here also patient will have severe pain, especially burning type of pain, which is gnawing type, and this will also result in stomatitis because of the erythema and all the painful conditions that are associated with it. Next important thing is cancer therapy. Yes, even in radiotherapy and chemotherapy, induced stomatitis is one of the severe side effects of this treatment regimen. In radiotherapy, what happens? Whenever a patient was delivered a 55 gray radiation, especially in the head and neck region. In these cases, what happens is the earliest symptom is mucositis, which can be graded as grade 1, grade 2, grade 3 and grade 4. And grade 4 forms a severe mucositis. In these cases also, the patient will have severe stomatitis related symptoms. Cancer therapy. In cancer therapy, the chemotherapy is one of the mode of treatment, where in chemotherapy there will be neutropenia. There will be neutropenia-induced stomatitis or neutropenia-induced ulcers. The ulcers here have a typical form where they will not have an inflammatory base. These will manifest just as an ulcers without having any inflammatory base beneath it. And this is a condition of hepatic gingivostomatitis. In this picture, we can see multiple ulcers which are present on the palate. As we see, palate and also on the oropharynx. This was a case of a HIV case, and hence we can see a severe manifestation of hepatic gingivostomatitis. And this is another case of hepatic gingivostomatitis, which is a normal patient. He has these ulcers only on the hard palate, especially in the anterior half of the hard palate. Here also we can see multiple pinpoint ulcers present, which is a pathognomic feature of the hepatic gingivostomatitis. Coming to various immunological conditions which will have manifestations like stomatitis include, primary is aphthostomatitis. As the name itself indicates, it is a lesion which is most commonly seen in the oral cavity. They are also called as recurrent aphthostomatitis because they continuously form, they are occurring in a phase of recurrency. They'll have continuous, on the episodes of healing and episodes of exuberance. In recurrent aphthostomatitis, we have again three different forms which include recurrent aphthostomatitis minor, major and herpetiform ulcers. These recurrent aphthostomatitis usually occur on non-keratinized mucosa, especially on labial mucosa, buccal mucosa and on the vestibular region. And in case of minor recurrent aphthostomatitis, usually the ulcers are less than 1 centimeter in size and they heal within 7 to 14 days of time, and they heal without scarring. In case of aphthostomatitis major, they are usually of larger in size and the healing period also is larger. It means that it will almost take up to 3 months of time for the lesion to heal. And these aphthous ulcers major usually heal with scarring. And we have herpetiform ulcers. These herpetiform ulcers are also a type of aphthous ulcers where they'll have multiple pinpoint ulcers. They are formed in clusters. About 100 ulcers form at one area, and these ulcers coalesce to form one large ulcers. Usually these herpetiform ulcers are outbreak because of any allergic reaction. For example, some patients will undergo scaling or oral prophylaxis. After a day or two, usually these patients manifest with this herpetiform ulcers. That means herpetiform. Why the name herpetiform is because they look like herpes induced virus, herpes simplex induced virus, but they come under aphthostomatitis. Behçet syndrome is another condition where it is usually immunological and inflammatory condition. And this Behçet syndrome has symptoms like of aphthostomatitis. It is an vasculitis reaction which will include multiple body systems. Next is erythema multiforme. Erythema multiforme is another immunological reaction where it is self-limiting and it will usually limit within 7 days of time. And this erythema multiforme is usually reactivated because of any drugs or any infections. Especially HSV is known to play an important role in formation of erythema multiforme. These erythema multiforme lesions usually occur on the vermilion border of the lip and in the oral mucosa also. They have a characteristic appearance of the ulcer which is known as target lesion or iris lesion. Next, other immunological mediated are pemphigus, pemphigoid, etc., which we already have seen how they form. That is because of IgG autoantibodies which are formed for the desmoglein protein. That desmoglein protein actually binds. It is a binding protein between the cells. Whenever these autoantibodies are directed towards this desmoglein 3, that binding between the cells is dislodged, and hence there will be breach in the epithelium, thus forming an ulcer. Usually, this pemphigus has they manifest as blisters and then they burst to give rise to ulcers. And next we have oral lichen planus. It is known to be a T lymphocyte mediated reaction. This will have a characteristic Wickham striae with multiple papules are present between them, and in this lichen planus also we have different variants like asymptomatic and symptomatic, whereas in asymptomatic variants we have reticular type pattern, etc., whereas in symptomatic we have erosive and ulcerative patterns, and these erosive and ulcerative patterns are usually responsible for the stomatitis symptoms. Like this, they'll have pain and difficulty in eating, etc. Whatever is the reason for the stomatitis, finally patient will have painful mouth, sores in the mouth, and patient will have inability to eat and to swallow, and sometimes they will also have difficulty in speaking. Whenever patient has difficulty in eating and swallowing, obviously there will be nutritional deficiency, which in turn will aggravate these conditions further. This is an aphthous ulcer where we can see an ulcer which is surrounded by an erythematous halo. This is a characteristic feature of an aphthous ulcers. These are usually well circumscribed ulcers and they have an erythematous halo around the ulcer. This is a pathognomic feature of aphthous ulcers. Here we can see aphthous ulcers on the lower lip. And this is angular stomatitis. Angular stomatitis is a condition usually present at the corners of the lip. And it has, angular stomatitis is usually a condition. It is not a separate disease entity itself. It can be manifested because of various underlying causes such as vitamin deficiencies like riboflavin deficiency, vitamin C deficiency, iron deficiency. In case of candidiasis also we can see angular stomatitis. And this is Behçet syndrome where we can see a deep ulcer here present which surrounded by an erythematous halo, which usually looks like an aphthous ulcer, but patient will have high recurrency of these aphthous ulcers, multiple lesions, very painful and deep lesions are present in these conditions, along with other systemic manifestations like vasculitis symptoms are also present in this Behçet syndrome cases. And this is a severe form of erythema multiforme where patient's oral cavity and tongue, all the mucosa and vermilion border of the lip is involved in this case. Patient has difficulty in eating, swallowing, etc. And there's painful mouth is also seen in this case. And this is a condition of erosive lichen planus where we can see erosions on the buccal mucosa. And other conditions which are associated as traumatic injuries, as we already discussed traumatic injuries like morsicacia baccarum. Usually along the plane of occlusal line, usually patients will have a hyperkeratotic. Few patients who have this cheek biting habit will have a linear alba-like condition where there will be keratotic borders will be seen. In cases severe cheek biting condition, there will be ulcerations and erosions seen there, which will result in morsicacia baccarum, and this case will have severe pain and burning sensation while taking spicy foods. And other traumatic injuries most commonly seen in buccal mucosa, especially at the third molar, mandibular third molar region because of irregular eruption, most buccally placed third molars. In these cases, they might have cheek biting and it further results in traumatic ulcers. And these traumatic ulcers usually have a characteristic condition also, that is, we can find a primary etiological agent as some trauma has happened. Second thing is, if it is because of tooth, we have a sharp margin. We'll have a sharp cut on the mucosa which is surrounded by an erythematous factor. Usually for a traumatic ulcer, the erythema is because, or erythema or pain or secondary inflammation is because of the secondary infections or superadded infections that are present within the oral cavity. Next, chronic ulcerative stomatitis. It is a generalized term where patient will have a long-term stomatitis like condition where there will be multiple ulcers. So this can be given as chronic ulcerative stomatitis. And one other condition is plasma cell gingival stomatitis. Plasma cell gingival stomatitis is a condition where there will be increased plasma cells are present. Usually it is one of the condition where allergic agents are also known to play action in it. For example, if patient has changed his toothpaste or patient is using newer medications suddenly, then plasma cell gingivitis can occur. So a proper and thorough history of the patient can elevate this plasma cell gingival stomatitis. And as I already told, these are the various etiological agents and how different etiological agents and how differently they are manifested to give rise to stomatitis. Coming to management of this, you can actually have a local therapy and systemic therapy. Most of the time, symptomatic therapy for the patient elevates his pain. Symptomatic therapy includes like topical application of anesthetic gels where burning sensation is relieved, and other local applications will include topical steroids, which includes triamcinolone estenoid 0.1% can be used. Various trade names are available for this like Kinocort, test, etc. And then we have various antibiotics which can help in decreasing this superadded infections such as tetracycline and doxycycline, where this tetracycline is usually the tablet of 400 mg, tetracycline 200 mg. It is powdered and swished, and then patient can either swallow or he can spit based on the prescription of his doctor or physician. Next, we have other steroids like dexamethasone, betamethasone. Betamethasone tablets are available where the patient can powder it and take it in the mouth. He can swish and keep it in the oral cavity for some time, and he can spit or swallow as per the physician's advice. This will help in reducing the inflammatory action that is happening in the oral cavity. Next, we have cyclosporine mouthwashes also are available, which will have this anti-inflammatory effect on the oral cavity and thus reducing the burning symptoms associated with the stomatitis. Other systemic therapies include corticosteroid, especially prednisolone. 1 mg per kg body weight can be given. In these cases, patient will have decrease in the inflammation and thus inflammatory related symptoms associated. Then we have various immunomodulators available, such as levamisole. Levamisole 150 mg can be given once daily for 3 days and for consecutive 3 weeks. This is one of the treatment modality to reduce after stomatitis, and thus it is also this immunomodulation. Along with immunomodulation activity, it has anti-inflammatory action also. Then we have cyclosporine, and other systemic therapies are also available, which are not so much tried, but they have been in the literature. Includes chlorambucil, dapsone. We have colchicine, azathioprine, and methotrexate. Other biologic agents, that is recent advances of biologic agents, are also present to decrease the inflammatory action and autoimmune conditions such as pemphigus and pemphigoid, and they include infliximab and etanercept. And other very important thing along with this topical and systemic therapies is diet supplementation. Diet supplementation includes proper food, because these patients have inability to take continuous food and all, so they will adequate liquid should be given, and all vitamin rich food has to be given to this patient, and diet supplementation should also be given to these patients. The topic for discussion is gingival hyperplasia, also called as gingival enlargement. Gingival hyperplasia is a condition where various different etiological factors are present. This gingival hyperplasia can be due to just hyperplasia, that is nothing but increase in number of cells. Hypertrophy, which is nothing but increase in the size of the cell. That is, number of the cells will be same, but there will be increase in the size of the cells. It can be due to edema, or it can be due to any angiogenic proliferation. For example, there will be minute small capillaries present within the gingiva, and there can be engorgement of these capillaries or blood vessels. Next, there can be because of any infiltration of cells such as leukocytes, or infiltration of granulomatous material such as in sarcoidosis, any other granulomatous diseases, etc. And there can also be increase in dense fibrous connective tissue within this gingiva. All these conditions will manifest as increase in the size of the gingiva, that is nothing but enlargement of the gingiva, thus resulting in gingival hyperplasia. This gingival hyperplasia is also called as gingival hypergenesis, and as I already told, there will be multiple etiological factors. Usually, most common among these factors is your acute gingival hyperplasia, which is because of the local inflammatory factors which are present on the teeth structures. Coming to the etiological factors, local inflammatory factors such as increase in calculus or the plaque deposition on the teeth will induce this gingival enlargement, thus resulting in gingival hyperplasia. How does the gingiva that has enlarged due to this material, that is local inflammatory conditions, look like is? Usually it is soft in consistency. It will lose the shiny or stippling nature of the gingiva. They appear more glossy, edematous, and they usually bleed on slight probing. Even in cases of mouth breathers also, there will be enlargement of gingiva. For example, usually in case of mouth breathers, what happens is upper gingiva is constantly exposed to the outside air or environmental condition, which will usually dry off in due course of time, and thus local inflammatory factors act upon that, and there will be enlargement of gingiva. Poor oral hygiene and any cases of food lodgement can also result in this gingival hyperplasia or gingival enlargement. Next is trauma. Traumatic conditions can also lead to gingival hyperplasia. One common cause is like nothing but some conditions like traumatic fibromas, usually seen on the gingiva, usually because of faulty tooth brushing, or while brushing the brush might slip and the bristles can injure the gingiva, thus resulting in traumatic hyperplasias, or this will again result in fibrotic hyperplasias. Usually they are more localized than a systemic condition. Any underlying bone disorder where because of this bone grows, or usually a physiologic conditions like tori can also present as gingival hyperplasia, but in these conditions it is not true gingival hyperplasia, only because the underlying bone is overgrown, it is been protruding outside, we feel like the gingiva has also been enlarged. Other conditions include drug-induced gingival hyperplasia, hormonal-induced gingival hyperplasia, any tumor infiltration such as in leukemia, etc. Vitamin C deficiency, which is nothing but scorbutic gingiva. Here also on all these conditions we can see gingival hyperplasia or enlargement of gingiva. In hormonal conditions, especially during the time of puberty or at the pregnancy, also called as pregnancy gingivitis, in these conditions, because of the hormonal changes, increased progesterone levels and estrogen levels, patients usually, female patients usually exhibit this gingival hyperplastic conditions. If at all the gingival hyperplasia is usually localized to one particular region, one particular tooth, then it is called as pregnancy epiloid also. Based on the etiology, this gingival hyperplasia is classified into various types. One is inflammatory condition. This inflammatory condition can be either acute inflammatory condition or a chronic inflammatory condition, and drug-induced inflammatory condition, drug-induced gingival hyperplasia. It can be hormonal induced hyperplasia such as in pregnancy and puberty. Sometimes it can be idiopathic gingival hyperplasia where the exact underlying cause is not known, and in conditions like plasma cell gingivitis and vitamin C deficiency, hereditary gingival fibromatosis, and conditions like systemic diseases which includes leukemia, granulomatous diseases and other neoplastic diseases, and there can be a condition called as pseudo enlargement also, where actually there is no enlargement of the gingiva, but because of underlying tissues enlarged, then it appears as a gingival enlargement. This is called as pseudo enlargement. Coming to vitamin C deficiency, it is one of the common causes seen in case of low socioeconomic conditions, people where their vitamin C deficiency is seen, and in these cases there will be gingiva hyperplasia. It is also called as scorbutic gingivitis. This scorbutic gingivitis is usually the gingiva in this condition is enlarged. The gingiva is usually soft and easily friable. It is like bruising can be seen, and there can be small pinpoint hemorrhagic lesions can also be seen on this. On probing, it usually bleeds. In this case, when vitamin C levels are replenished in the patient, then this scorbutic gingivitis automatically comes down. Next is leukemia. Leukemia is one neoplastic condition where there will be infiltration of the leukocytes into the lymphocytes into the gingiva. The appearance of gingiva in leukemia is usually boggy kind of gingiva. Here there will be severe enlargement of the gingiva, and it usually covers up to 2/3 surface of the teeth. And in leukemia, gingival hyperplasia is most common in condition of AML, that is acute myeloid leukemia, when compared to ALL, CML or CLL conditions. And next is squamous cell carcinoma. This is again squamous cell carcinoma of gingiva associated with alveolar mucosa or underlying bone. It is one of the most common kind of oral cancer that has been recently seen. In this condition, what happens is because of the infiltrate or neoangiogenesis or because of the cellular hyperplasia, there will be enlargement of gingiva. It is usually localized in condition, and it is one of the most potentially fatal kind of condition. And next is Kaposi sarcoma, usually seen in case of HIV AIDS patients. It is a AIDS defining condition also. This Kaposi sarcoma, to see it usually looks like a hemangioma like lesion, and most commonly seen on the palate, and also it involves the gingiva. In this condition we can see Kaposi sarcoma which is overlapped with, superimposed with candidal infection. Based on the distribution and location, this gingival enlargements can be grossly classified as localized, generalized. It can based on the location of the gingiva itself, like marginal, papillary or diffuse, and based on its distribution it can be again classified as discrete kind of gingival enlargement. Coming to inflammatory gingival hyperplasia, the main causative agents for this inflammatory gingival hyperplasia includes plaque, food impaction and calicles. And there are certain aggravating factors also here, such as puberty and pregnancy and other immunological conditions, or patients' immunosuppression condition also can lead to this inflammatory gingival hyperplasia. These are nothing but the aggravating factors, but the main etiologic factors are always any food impaction, the calicles and plaque formation seen around the gingival areas. Usually in inflammatory gingival hyperplasia, the gingiva is glossy, bright red to purplish red in color. It is edematous and it easily bleeds on probing or slight provocation. In these cases, one of the pathognomic sign we can see is patient will have halitosis. Usually patient himself complains with a chief complaint. He comes to us with a chief complaint of bleeding on while brushing or while eating hard food. At these conditions, primarily when the etiological agent, that is calculus or plaque, is removed, most of the times it will not progress into inflammatory gingival hyperplasia, but if it is left unattended, it can lead into inflammatory gingival hyperplasia condition. So this is a picture of localized inflammatory hyperplasia. In this we can see pyogenic granuloma. The final diagnosis was pyogenic granuloma. Here we can see on probing there was a pseudo pocket present. That is, as the gingiva itself was growing onto the tooth surface, instead of loss of attachment, we can see a pocket there. But actually there was no loss of attachment. It was only because of the overgrowth of gingiva we could find a pocket there. So this is called as pseudo pocket or false pocket. Next is inflammatory gingival hyperplasia due to calculus. Here we can see it is the same patient. The lower teeth we can see much of the calculus and stains that are present, and upper teeth are relatively, they don't have much of these deposits. That's the reason at the lower anterior region we can see enlargement of gingiva, whereas in the upper anterior region there is no much enlargement of the gingiva. Next, it is in inflammatory gingival hyperplasia in severe cases can progress into periodontitis, as sometimes can land up in formation of pseudo pockets. In long-standing cases, this gingiva of inflammatory gingival hyperplasia can become relatively firm and it loses the normal resiliency of the gingiva. And on probing, they generally do not bleed readily in case of long-term or chronic cases. Histology of this inflammatory gingival hyperplasia condition usually has number of inflammatory cells present within that, and they have vascular engorgement, neoangiogenesis, and certain other degenerative changes. Next is coming to drug-induced gingival hyperplasia. In this condition, certain drugs has this tendency of causing gingival enlargement. Here, one important thing is it is not because of formation of new fibrous tissue there, but it is because of dysregulation of the cytokine production, which actually helps, which actually is responsible for the fibrotic tissue formation. Whenever there is this dysregulation of this cytokine, then we can see a gingival hyperplasia. Whereas drugs that actually cause this drug-induced gingival hyperplasia includes anticonvulsants like phenytoin, vigabatrin, phenobarbital, valproic acid, phenytoin being one of the most common cause of drug-induced gingival hyperplasia. Another thing is cyclosporine, and we also have other drugs like calcium channel blockers including nifedipine, amlodipine, diltiazem and verapamil, which also causes drug-induced gingival hyperplasia. Among these various drugs that actually cause this gingival hyperplasia, the gingiva has a characteristic appearance of more fibrotic. But in cyclosporine, the gingival hyperplasia resulted due to cyclosporine is little softer in consistency when compared to these other drugs. Hence, what is the treatment of that can be given for this drug-induced gingival hyperplasia is very simple. It is either withdrawal of the drug or change of the drug. For example, instead of cyclosporine, giving tacrolimus, which is 100 times more potent than cyclosporine but has lesser side effects, like it will not result in gingival hyperplasia. So, with the help of physician consent, this cyclosporine can be replaced with tacrolimus, thus reducing this occurrence of the drug-induced gingival hyperplasia. Similarly, various new generation drugs are available even in anticonvulsants and calcium channel blockers to prevent the formation of gingival hyperplasia. There will be characteristic appearance, that is usually initially the interdental gingiva is affected, further in the anterior regions, further it progresses into the attached gingiva. Diagnosis is usually based upon the chronic drug usage of the patient, that is proper medical history and the drug history of the patient will help us in coming to a diagnosis. Coming to hereditary gingival fibromatosis, it is usually a genetical disease, that is it has a genetic predisposition, and usually it can be seen even at the stage of birth, directly at the stage of birth, or when the teeth are erupting, either the primary teeth or permanent teeth are erupting, this disease usually manifests. There will also have a tooth migration. Patient will have diastemas, there can be prolonged retention of the deciduous teeth and poor aesthetics. There will be difficulty in mastication also because of the overgrowth of the gingiva, and these come onto the occlusal surfaces and patient will have difficulty in chewing. Coming to plasma cell gingivitis, also called as atypical or plasma cell gingivo-stomatitis, like it affects both gingiva and also the other buccal mucosa, labial mucosa, other mucosal surfaces of the oral cavity. It is usually has an allergic etiology, like when patient has recently changed his toothpaste or when he is using a newer drug, etc. This can usually manifest like plasma cell gingivitis. Plasma cell gingivitis, the gingiva is usually red and it will have very mild enlargement. Enlargement is not very severe like it other condition, but the patient will have mild enlargement. But most pathognomic feature is it is red in color with erythematous region, usually friable, and it bleeds on probing or slight provocation. Other associated symptoms associated with this plasma cell gingivitis is cheilitis and glossitis. This is a picture showing plasma cell gingivitis on the attached gingiva on upper and lower teeth. So these are the various causes based upon the etiology and based upon the distribution. Gingival hyperplasia can be identified or diagnosed, and the management involves, first thing is underlying cause has to be treated. For example, if patient is having any other inflammatory conditions like plaque etc., poor oral hygiene etc., then giving proper oral healthcare precautions and oral prophylaxis etc. can reduce it. And other conditions like underlying vitamin C deficiency, replenishing with vitamin C can reduce corbretic gingivitis. If patient is having leukemic conditions, treatment with leukemia can reduce this, especially in AML, can reduce gingival hyperplasia etc. So underlying condition has to be treated first for treatment of gingival hyperplasia. Other other process for management includes elimination of local inflammatory factors. Patient should be trained to establish a good oral hygiene practice, and if patient is having any habit like mouth breathing, which is one of the cause for gingival hyperplasia, elimination of this habit is important. So habit breaking appliances has to be given like oral screen etc., and change of the drug or withdrawal of the drug has to be done in cases of drug induced gingival hyperplasia. Some cases will call for a biopsy. This has to be done because few of the neoplastic conditions can manifest as gingival hyperplasia. If at all the lesion is suspicious, even after removal of all inflammatory conditions and treatment of underlying diseases, still the enlargement is present, then do not hesitate to have a biopsy, check for the biopsy and exclude any neoplastic conditions from there. If at all there is a neoplastic condition, further cancer therapy has to be induced for the patient, whether it can be a surgical therapy, chemo or radiotherapy. Usually gingiva buccal sulcus cancers are treated with surgical mode of treatment. Next, in case of refractory cases, we have to give adjuvant antimicrobial agents, because most of the time what happens is the oral microbial agents which are present or any superadded infection can prevent healing of these lesions. So in such cases, antimicrobial agent will be helpful in treatment of the gingival enlargements. Gingival debridement is one other reason. In case of fibrotic changes of gingiva, most of the time surgery would be the final option, because how much ever medication you give, the already formed fibrotic agents might not get resolved. In these cases, we will go for gingival debridement, periodontal therapy or osseous recontouring. We also go for labial ablation gingivectomy, laser ablation gingivectomy or surgical approach. In laser ablation gingivectomy is a newer process that is being used. Here what happens is we use a diode laser or carbon dioxide laser. Most commonly diode laser is being used. By using this diode laser, the gingival surface has been ablated, or you can either do a gingivectomy procedure. Gingivectomy is nothing but removal of the, cutting ectomy. It is the removal of that excess gingiva. You can either go for gingivectomy or gingivoplasty. Gingivoplasty is a condition where you will, instead of removing it totally, will recontour the gingiva, the soft tissue, removing the excess of gingiva that is present. Laser ablation will be helpful in reducing more bleeding complications, because with the help of laser, it is usually less painful procedure and bleeding can also be stopped. Much of the bleeding can be prevented with the help of laser ablation. Thank you.